Well, good evening, everyone. Welcome to this meeting of the Health and Adult Social Care Overview and Scrutiny Committee. My name is Councillor Patrick Canavan, and welcome to everybody that's in the room and also that is joining us online. So I'm just going to ask the Democratic Services if you would read the housekeeping notice, please.
Thank you, Chair. Please note that this meeting is being recorded by the Council for live broadcast and will be published on the Council website for a minimum of 6 months. The meeting may also be recorded or streamed for live or subsequent broadcast by members of the public, although ultimate discretion in this matter lies with the Chair in case of disruption. For those in the room, please note that if a fire alarm sounds, please exit the building by way of the nearest available signed fire exit route and make your way to the assembly point in the front car park of this building. Finally, please ensure background noise is kept to a minimum and mobile phones and other devices are turned off or switched to silent for the duration of the meeting. For those in the room, this includes turning off microphones, turning down the volume on your laptops completely. Thank you.
Thank you very much. And do we have some apologies, please?
Yes, Chair. We've received apologies from Councillor Hazel Allen, Councillor Leslie Dedman, Councillor Judy Richardson, Councillor Chris Rigby and Louise Bates this evening.
Thank you. Substitute members.
Councillor Joe Salmon is subbing for Councillor Rigby this evening.
Thank you. So the usual item of declarations of interest, please. Anybody?
Oh yeah, I continue to work for Dorset Healthcare.
Thank you very much indeed. So if I can take item 4, which is the confirmation of the minutes. So unless anybody has any particular issues or concerns about the minutes, are you content that we accept those minutes as a correct record? Thank you very much. And again, the action sheet is there for noting. There is an item on there in respect of homelessness or healthcare provision for, and we'll come back to that when we get to the work plan. Are there any public issues?
There are no public issues this evening, Chair.
Thank you. So moving swiftly on, item 6 is the Bournemouth, Christchurch and Poole Safeguarding Adults Board Annual Report for 24-25. And it's my pleasure to invite Sean Walker McAllister, who's the independent chair of the Dorset and Bournemouth, Christchurch and Poole Safeguarding Adults Board, to present this item. That's a lot to say, isn't it, Sean? But thank you very much again for coming in. We have got your report, but anything you'd like to highlight would be brilliant. Thank you very much.
Thank you. It is a bit of a mouthful. So, and thank you for inviting me. My statutory duty is to present it to the Health and Wellbeing Board, but it's always an absolute pleasure to present it to Scrutiny, to give members the opportunity to have a little more depth about the report. Excuse me. The Safeguarding Adult Board was created under Section 45 of the Care Act and has statutory responsibility for a few things. One of those things is to produce an annual strategic plan. Ours lasts for 3 years. It's to work cooperatively with partners to ensure that all our statutory and non-statutory partners are all going in the same direction in respect of adult safeguarding. It's to produce an annual report to set out how we've achieved our plan. And it's to commission safeguarding adult reviews in the event of a death or a serious incident in respect of an adult with care and support needs who's been unable to protect themselves from abuse, neglect or harm. So I'm not going to go through the report in detail. You've seen it. We try to make it as accessible as possible. This year we used a PowerPoint format to do that. So I'm not going to bore you with going through slide after slide. But I do want to perhaps remind you that this report is for the year 24-25. So it takes us up to the 31st of March 2025. And it is a real reflection, I think, of the work that we jointly do with our partners. The report is co-produced with our partners. The 3 statutory partners in adult safeguarding, slightly different from children, are the police, the NHS and adult social care. And in adult safeguarding, adult social care is the lead partner. So the data that you actually see in this report, and I haven't got page numbers on my hard copy, so apologies, but a few pages in, actually reflects the data provided to us for the year by Adult Social Care, and the data which Adult Social Care send in to NHS Digital at the end of March every year to account for their safeguarding activity through the year. There's no other statutory requirement on any of our other partners to collect this data, but as it all comes in through the adult safeguarding front door and the adult social care front door, we're assured that this is the way we should collect the data. In respect of the data, there's not that much difference from the year before. There are some percentage differences in some of the areas. If one compares it to national benchmarks, it's not remarkable. It's not an outlier. We show in the data that there were nearly 6,500 safeguarding adult concerns received, and only 1,344 of those progressed to a full inquiry. And that's quite normal, and it varies from place to place. One of the things which BCP Adult Social Care does is encourage everyone to report a concern. But because often people report concerns that don't meet the criteria for a safeguarding adult inquiry, BCP Adult Social Care will divert those into the appropriate place. And what that means, and where I have that assurance, is that people aren't slipping through the net. So somebody may raise a safeguarding concern, and the outcome might be that the staff at the front door who receive it say, actually, this person needs a Section 9 Care Act assessment to have the care and support needs assessed to see if they meet the criteria for some support. Or it might mean that they meet the criteria for some voluntary or community sector input as commissioned by the council to support somebody in respect of a particular issue, or perhaps some input from another partner. It may be a GP, and sometimes it's about a phone call between adult social care and the GP to clarify the issues that have been raised. We don't just receive this data annually. The data is analysed in quite some depth at one of our subgroup meetings, our quality assurance subgroup, which meets quarterly, and that data is then analysed for any trends, and from that we decide, can we is there a pattern here? Is there something that we need to take a deep dive and look at in more depth? You'll note from the report that we now have an additional subgroup of the board. That subgroup, the Mental Capacity Act and Deprivation of Liberty Safeguards subgroup, another mouthful, is chaired by your own Betty Butlin. And we decided to create a subgroup in respect of those issues because there were some data trends which were showing that we needed to have a greater focus on the Mental Capacity Act. And it's interesting because, again, that data is not specific to BCP council area. It's common, and many other boards have had Mental Capacity Act subgroups for a couple of years. So I think this report also publishes, I don't think I know, this report also publishes the data of one safeguarding adult review about Edward, which was published during this year. He died prior to the year, and two young boys are currently in custody for his murder. There's a brief synopsis in the report. I won't go into any detail, but suffice to say, it's enabled us to follow through on a lot of areas as a partnership, working together to make sure people have a better response to something which is known as cuckooing or house takeover, when often vulnerable individuals have their houses taken over for the purpose of illicit activity, which might be drugs or other coercive controlling activity. I don't think I should go into anything else, but leave it open for questions because I know I only have 20 minutes. Thank you.
Thank you very much indeed. Any questions from members of the committee? I wonder if I might just ask one quick one. You touched on it slightly in your presentation. So the report includes the safeguarding activity for 24-25, and it includes a breakdown of the ones that are concluded at section 42.2.
Yep.
But I'm kind of just looking at the preceding column of the concerns received. Now, you did touch on that. So I'm just asking, I guess, what what we do with the ones that don't proceed to section 42.2, if that's not a daft question.
Okay,
Are
perhaps
you,
I
are you looking
no,
for?
no, not a daft question at all, and perhaps I didn't explain properly. Often a safeguarding concern will be referred in through the adult social care front door, and those receiving it and triaging that information will look at it and think, actually, this person needs a Care Act assessment, needs a full social care assessment, and this isn't actually a safeguarding inquiry. It's also the case that some providers of social care in residential care homes quite often refer safeguarding concerns that might be missed medication or might be a fall of somebody who's quite vulnerable in a care home. And that doesn't really meet the criteria either, unless there was a pattern identified from one particular care home. And you'll be aware of scenarios when patterns are identified and when intensive safeguarding work takes place with a particular care home. So those are amongst many of the issues which come in as safeguarding concerns, but don't actually need to be carried through to an inquiry. And the figures that we see, 1,381 out of the 6,291 that were referred during that year. It's quite a normal percentage. It usually averages around the sort of 20%, a bit below or a bit above, for concerns that are carried through. But it does give the opportunity for adult social care to make sure that nothing's missed and refer to appropriate services that they may commission. That might be an assessment. It might be straightforwardly referring somebody to a commissioned service. Does that explain it better?
Thank you very much indeed. Betty?
Yeah, thank you. And thank you, Shan. Just to add to what Shan kind of touched on, I think it's about making sure that at the point of the kind of concern coming into the adult social care hub, that you have the right triage and measures in place, so that you have skilled practitioners, which we do, and particularly more so now than ever, because we have remodeled or reconfigured our adult social care hub, where we have practitioners there that are specialists in safeguarding, and the staff within that area are able to really sensitively triage. So therefore, you don't have somebody progress into a section 42 inquiry where there might be a more appropriate route, some of which Shan has touched on. It might be more appropriate for a social worker, for it to be passed to a social worker in a relevant team, or in many incidences, it might be more appropriate to go to our service improvement team as well, and not necessarily go down the section 42 inquiry, which is a more detailed investigation and inquiry that will take place. But that said, with that really good triaging, it doesn't preclude anybody going down to a section 42 inquiry if there's reason for that to be necessary or for that to take place. So they work both well together, the triage and then progressing to either a concern or an inquiry. Thank you, Chair.
Thank you very much indeed. Any other questions?
Could I?
Lisa?
Oh, yeah. Thank you. I just wondered, is it possible ever for a member of the public or, say, a councillor to bring forward a theme that they feel is a safeguarding issue and ask you to look at it? Is there a function for somebody to do that?
No, because we're a strategic board, we're not an operational board. So if you have a safeguarding concern, you would need to raise that directly within adult social care, within the council, or if it was nothing to do with adult social care, with any other of the partners to which that might relate. But quite often we get referrals of say a member of the public might not be satisfied with the way somebody's responded to something, and they contact or find out who I am and contact me, and we're very specific that in terms of our board, not being operational. We have a complaints procedure or a referral procedure that is only about the activity of the board and a complaint about the board. So if somebody was complaining about one of our partners, they need to go through the partner complaints procedure first, or the partner concern raising procedure. So if members, for example, in a scrutiny committee, were starting to see a theme of something that through their constituency work, through discussions with Betty and with other people, then the first point of call would be through Betty to raise that. And it might be that Betty might say, actually, that would be really interesting. Maybe we can ask the board to look at some of the data with us, and then the board might decide, yes, actually, you've raised a really important thing here. Thanks for contacting us. We're going to do our own little bit of deep diving as well to sort of find out more about it and see what can be learned. The main purpose of the board is to bring partners together at a strategic level so that we're all working together. And to give one example of that, which doesn't directly relate to adult social care, but does absolutely relate to it, is the police activity known as Right Care, Right Person. And it's around how the police are called to intervene in cases of people who are severely unwell. And the board has held some oversight on that, because often that activity coincides with the need to safeguard somebody, and we want to be assured and have provided some governance over that any change in practice, either by the police or any of the partners, has not left anyone vulnerable in our community. So it was a major strategic change on behalf of one of our statutory partners, and we've decided to take an overview on that. We'll also be taking an overview on the implementation when the new mental health legislation and the new liberty protection safeguards legislation comes in future years to replace the deprivation of liberty safeguards as they're now known. And we'll be ensuring that we, through the Mental Capacity Act and DOL subgroup, we'll be having good governance and good oversight of the data of activity there to make sure that everyone is pulling together in the same direction to deliver safe services for people living in Bournemouth, Christchurch and Poole.
Thank you.
Thank you very much. Any final questions? If not, Sian, thank you very much indeed for your report. I'm sure we'll see you again next year. But I'm going to move swiftly on to item 7, which is the Adult Social Care Compliments, Complaints and Learning Annual Report 24-25. And I think I'm inviting Betty and Nikki Mitchell, who's the Head of Transformation and Integration, to present this item.
Thank you. Bye-bye.
Thank you, Chair. Yeah, I'm just going to introduce the report, and then my colleague Nikki, who is to my left, is going to talk us through the report. We have a duty and a responsibility to produce a annual report around complaints and compliments, and to have that report scrutinised in forums such as where we are today. So this is the annual report for 24-25. And it's governed under the legislative framework of the local authority, social services, NHS service, complaints regs. So I'm now of 2009. So I'm now going to hand over to my colleague Nikki, who is going to share some slides with you that will be easier than going through the detail of the report. Thank you.
Thanks, Betty. Yeah, just a very short presentation, really, just some key highlights from the report. I'm sure everyone's read it, so there'll be an opportunity for questions. But just to summarise, really, so we had 195 complaints this year, or this reporting year. I had 180 the previous year, out of around 12,000 people that we support. It generally fluctuates between sort of 180, 190 complaints. And we also had a total of 202 individual concerns and general inquiries. So a bit like the safeguarding, we have a lot of phone calls coming in, but actually maybe the complaints process isn't the right way to manage it, but we'll signpost people out or support them in other ways. So busy team. We've had 59 MP or councillor representations this year compared to 39 the previous year, and that is a growing number actually. Over the last few years, we've seen more and more representations on people's behalf from their MP or the councillor. Inquiries, councillor inquiries are dealt with in a number of ways. Sometimes they'll be dealt with by director or legal and demographics team, or we will go into a complaint investigation if necessary, and we will require appropriate consent to do that. Moving on to our compliments, ombudsman complaints and our compliments. So we had 3 ombudsman investigations this year. So our complaints process is a statutory process, and it's a 1-stage process locally. So we have 1 opportunity to respond and investigate, and then if the person remains unhappy, they then escalate it to the local government and social care ombudsman. So we had 10 referral or 10 investigations last year, but only 3 this year. It's important to note as well that 13 further complaints were referred to the Ombudsman, but the Ombudsman chose not to investigate them because they felt that we'd either done full investigation already, they couldn't offer anything else, or perhaps the person had come to the Ombudsman too soon and they were directed back to us. So we work closely with the Ombudsman in that respect to make sure things are dealt with in the right way. So far we've had, so out of those 3 complaints, 1 was upheld and 2 we're still awaiting decision. So our common complaints themes around communication and that perceived standard of service and professional practice, finance and charging, and then some complaints around decision in around assessment or eligibility were our kind of top 3. And it's important to note always that we've got 219 messages of thanks or appreciation or compliments. So it's nice to see that we have more of those than we do complaints. Just a bit about the complex complaints, and this has been a national picture over the last couple of years. They're really, really complex now. We record complaints and themes in a number of ways. So 1 complaint might cover communication, finance, all sorts of different themes. So we really look into those so we can learn from them. We have a lot of repeat complainants now, so people can bring obviously more than 1 complaint. They're quite within the right to do that. We can't answer the same complaint twice. The next stage is for them to go to the Ombudsman. But the team spend a lot of time supporting people around the complaints process. Sometimes it can become quite protracted if people aren't happy and they keep coming back. So we put a management plan in place to communicate with them so they know, you know, where the structure is and how we manage those complaints. We do have an unreasonably persistent complaints process, and we've had to use that 3 times this year because if someone meets the criteria for that, that might be that they keep coming back with the same complaint, that, you know, that they need help kind of understanding and the process and being able to put it to bed. So we do use quite a structured way of managing those complaints. And yeah, various individual communication plans with people as well to help them understand the process and to get the outcomes that they need. So in terms of organisational learning, so we have our quality improvement framework, and monthly we have a senior management team performance and quality improvement board where we scrutinise learning from things like complaints, and we triangulate it with our other feedback that we get on our performance data. So a good example this year is our OT and DFG complaints. That was the Ombudsman referral. So we realised that these complaints were happening. We looked at our OT data and we put some actions in place to improve that. And we've got much lower waiting lists for our OTs now, and we've improved the DFG process. And we've actually got a member of staff, a new post that sits across housing and adult social care to speed up those disabled facility grants applications. So that's kind of how we feed complaints into our wider learning for the organisation. So it's just some examples there. They're in the report, but just sort of to point out individual learning for individual practitioners will be taken up. We have practice learning reviews, which are short sort of reflective sessions with managers to look at practitioner practice. So if there's a complaint that comes in for a particular practitioner, we will pick it up that way. In terms of finances, we will review people's cases. If they complain about their eligibility or any finance issues, we will review their cases in case there's, you know, any inaccuracy. We had a complaint around transitions process, so we reviewed that process between children's services and adult social care, and we now have more meetings in place for when people are approaching 18, so we can work more closely together. So that transition is more seamless. And in terms of delays, we did have complaints around delays in 24-25, but as hopefully you'll know, our transition work is really helping us to deal with our demand differently in that respect, and we are reducing our waiting times. Less people are going through to needing that long-term support. And using a conversational approach, we are now reducing the length of time people wait. Our mean wait for a conversation one is 29 days now, as opposed to 75 days for a character assessment this time last year. So we're really, monitoring that through complaints and making sure that those complaint themes are declining. And our carers vouchers and direct payments, we had some complaints around our carers vouchers. Providers weren't accepting these vouchers any longer. It was harder and harder to use them. So, and our data around direct payments were telling us that the uptake for direct payments wasn't good enough for carers. So we removed the vouchers and really driving our carers direct payments now and giving carers that choice and control. One person did complain about the communication we had around that change. So we then wrote out to all carers that we had so they knew what was happening. And our direct payment uptake is now is rising rapidly. We've made great improvements with that, and we're getting some really positive feedback from carers. The example I like is one person was caring for his wife, and he just really he didn't want to leave her on his own, but wanted to go out in the garden and just have a cup of tea out there and have a break throughout the day. So we provided him with a garden furniture, so he now has got somewhere to sit at the end of the garden and have that break, rather than us having to try putting respite that perhaps neither of them wanted. And so we're trying to be more creative with our approach and that choice and control. So yeah, some lovely stories there. So yeah, that's any questions? Thank you.
Any questions? Councillor Dara.
Hi, thank you for that. It's good to hear about the furniture. I think that's really creative. I'm just looking at the actually the number of complaints reserved within 20 days, and it's gone down from 62%, which to 61% this year, or last year, 24-25. And I'm just wondering, because you said it was an issue with staff being a problem. But I've noticed that there's been no increase in the amount of staff being able to deal with complaints. Is that correct?
Hello. So our responding managers are the appropriate team manager or service manager whose complaint is, whose team it is. I think sometimes the 20-day target isn't reached because they are operational teams, they might be very busy. We always keep in communication with the complainant. So if we're going to be a few days over, we would always tell the complainant so they know what's going on. The 20 days is a best practice. It's not a statutory guideline. So we do try and stick to that where we can. One thing we have done this year and we're starting to do is tell the managers that you've got 15 days to respond to this rather than the 20. So, we get those complaint responses in earlier, and we've increased our amount of our complaints training as well for managers. So we've got sessions running over the winter. And we had some at the end of the summer, and that kind of helped pick things up, really. I think managers were then much more aware of the process and what best practice was. So we are trying to improve that.
So 20 days, is there, so you said about the training, have you noticed an improvement since that went in? So this is up to April 25, isn't it? So
Yeah.
between then and now, have you got figures that actually says this is improving?
Yeah, we have, and also the quality of our complaint responses as well, I think is better. Managers are more understanding of how to, because I think sometimes that can delay it. They'll write a response and then it will come to our complaint team for that kind of quality assurance to make sure that we've answered everything. And sometimes if we then have to go back to the manager, that can delay things, whereas that's not happening so much now. We are getting those complaint responses out quicker.
Thank you.
Yeah, Mr. Matthews.
Thank you, Chair. Excellent report. I was just actually looking at some of the compliments I think are amazingly powerful. And so obviously this is just a small sample of that. As part of the sort of learning process for team development and stuff, because where people learn from things when they go wrong, I'm assuming you actively share the good stuff as well, because actually people can learn so much from that, particularly from people who are experiencing, because I think some of these comments are incredibly powerful and, you know, fantastic evidence. So thank you.
Betty.
Yeah, and just kind of picking up on some of your points and yours around the compliments and the learning, but also around the delay sometimes in getting to things. I think it really does depend on what the circumstances are as well, and what your approach to that complaint is going to be. What's the best way to get the best outcome for that person or and their families? So sometimes it might be that you're actually saying to them, do you know, I think it would be really good if we meet, rather than just keep emailing or keep going through, you know, letters and different things like that. And we're really encouraging our managers and, you know, those people that are involved in it to meet with people and have the conversation. So sometimes the logistics of that on both sides, not just on kind of, you know, the practitioner side or the manager side, it can take a little bit of time. You know, I certainly meet with people, and I know sometimes it's about what's the best time for them around their care and responsibilities. You know, is it easier to do that? So I think it's really important to kind of not get caught. It's important to respond and to acknowledge that you're going to do something and that you're looking at it, and maybe we should get together. But not to rush that so that the person feels that's not a good option for them, but to acknowledge it and to be talking to them while you're doing that. And the learning from you know the compliments that come, especially from peer to peer. You know, if you have a social worker and they're saying, you know, oh, I had this and I didn't even realize it was something that they would be really pleased to have, but they were. So, you know, that's a really good thing. And then that kind of gets around the team and then other people, and they really do learn from it. And it's good to receive both, not to always just receive one side of it. Thanks. Thank you, Chair.
Just quick, yeah, I think that's really good that you've actually said about the fact that the quality of the response may delay how quickly it's happened. So I think that's really great. Thank you.
Thank you very much. Any other questions? I wonder if I could just ask you just to help me a bit with the process. So, you know, coming back to the point about how complex some of these cases are. So if you get a case that comes in, and whoever receives it realizes that it actually touches on other services, housing or partners, does the onus still rest with you or your team to pull all of those partners' responses in and then communicate that to the person?
Yeah, so we deal with joint complaints in a number of ways. We've got the centralised complaints team now, which so all of our complaints go centrally, but we have an adult social care specialist that deals with our complaints. But if so, for example, we have a complaint that spans children's services, we will decide between us who leads on that complaint, and often it will be the person who's got most of that complaint. They will lead on that and work with partners to do that joined up response. But we also have a wider a joint protocol with our health partners as well. So if a complaint goes into the hospital, but it also involves our hospital social work teams, again, we'll talk to the hospital teams and say, okay, who should lead on this? And just, it's communication, isn't it? And working in partnership to see who's going to lead. There's no statutory guidance on that, but we do that sort of locally, work that out together.
Okay, thank you very much. So the recommendation on this item is to consider and scrutinise the information contained in this report and to consider any actions or issues for inclusion in the work plan. So if there's anything that occurs to anybody that's the opportunity to say so. Otherwise, we'll thank you very much for the report and we will press on. So thank you again for your time.
Thank you, Chair.
If you want to go.
Thank you.
So we're going to move on to item 8, which is the future care programme mid-programme review, and I'm back to Betty, I think, as well on this.
Yeah, thank you, Chair. So I'm just going to introduce the paper and then I'm going to hand over to my colleague Ed, who is working with us as one of our strategic partners in the Future Care programme. So just to remind members that this is probably at least the third update that you've had now on this programme, Future Care. So we agreed that it's been agreed that ONS would scrutinise and oversee and monitor the Future Care programme. So the purpose of it coming today is to provide an overview and an update of where we're at with the Future Care programme, and to provide the assurance on the benefits already achieved, and also an outline of the actions in place to deliver the remaining scope of the programme. And as I've said, it's a requirement for the report to come back periodically to this committee. So if it's okay, Chair, I'll hand over to my colleague Ed, who is going to take us through some slides that you can see on the screen that condensed down the paper that I'm sure you've already all read. Thank you.
Thanks, Betty, and good evening, everyone. Yeah, in October, we passed our mid-programme point, so it felt like a good time to bring this back to the Overview and Scrutiny Board, and it's going to equivalent boards across Dorset Council and all of the partner organisations. As you'll know from hearing about this previously, this is a joint endeavour across all health and social care organisations within Dorset County. I won't repeat what Betty's already said. So just to remind everyone that the programme launched in January earlier this year with a real aim of recognising the pressure on hospitals, both within Dorset County but also nationally, to improve hospital discharges, recognising that being a key area of pressure found through the diagnostic completed last year in 2024. And actually, as well as flow within the urgent and emergency care system, there's a real opportunity to improve long-term outcomes, and we get it wrong. Obviously, that has a long-term impact on those people that benefit or don't benefit from interacting with the health and social care system, and to do that, focusing on recovery at home as well. And to do that, we were organised in 4 delivery work streams, each sponsored by a system partner executive. So that's a key way of making sure that we're keeping all of the organisations, I suppose, tight and close to the programme, recognising that this, more so, well, as much as anywhere, requires the collaboration of all of those different partner organisations. So there are 4 work streams. The first was around alternatives to admission. So that's really around reducing pressure at the front door, looking at exploring alternatives when, rather than admitting to hospital, have we exhausted all other alternatives before going to that point. Transfer of care, so now looking at the sort of the back door of the hospital, focused around complex discharge and ensuring that no one waits longer than they should do, unnecessarily waiting to be discharged from hospital because of either a blocker that stops them going home or a blocker that goes them going onto their sort of long-term setting. And that then leads into the final 2 work streams, which are really around how have we got sufficient capacity and the right capability within our intermediate care services to ensure that we can get that transfer of care process working effectively. And each of those 4 work streams then contributing to the whole. So where are we this is as of early October, when the report was sort of published and as same circulated by all partner organisations. So we're projecting that we're at about just shy of £13 million of an annual operational run rate of benefit to the whole system. That's spread across all 6 organisations, not just to any one organisation. That's slightly ahead of the target of 12.5, but we recognise, and I think it's outlined in your paper, that this run rate, we're sort of on the upward trajectory, and so we need to keep up each month with further improvement. And looking specifically to BCP, I think despite there being early pressure on residential starts that was driven by a spike in residential starts around the Easter time, we are on track to deliver the planned savings that's been baked into BCP's Council's medium-term financial plan, at least against this saving programme. And I guess the critical thing here is that this is, I think it says as much in the paper that Dylan and Betty wrote, but it is the benefits are backloaded to the council. So really the price is in the sort of future years. So although it's relatively modest in 25, 26, that stacks up into future financial years. And then looking at those delivery work streams, to call out a couple of examples, recognise only 20 minutes, so we'll keep them to the high level ones, but in bed-based intermediate care, so these are all intermediate care beds across the county. In Dorset, you have around 200 beds provided by Dorset Healthcare, the Community Health Trust, but also a selection of intermediate care beds provided by both councils through their through Tricura and Care Dorset. And so this work stream was looking not just at one, it was looking at all of the beds provided across the Dorset County, and that's reduced from a baseline level of about 39 days down to about 33 days in October, and we're targeting going further to 30 days. So we're already 5 days less, which is any sort of, recognising from the diagnostic that there were people spending longer than they needed to in these settings, which meant that they were potentially deconditioning from their further on, moving on to their long-term setting, but also critically blocking the capacity of these critical services for more people who are being discharged from hospital. And really, really importantly, we're getting that increased flow without the cost of long-term outcomes. So the second stat there, we've seen a 30% reduction in ongoing care home placements after a stay in intermediate care, so more independent outcomes, which is really the goal. And then same day emergency care, so this is that alternative to admission work stream. We found that how we maximising, we have many great services in Dorset that are all about maximising the opportunity to avoid an admission wherever possible. And we've seen a 10% increase since the start of the programme in those services, and really positively for UHD particularly, sort of the important metric to track there, as well as how many of those total attendances of everyone turning up at university, at our acute hospitals, how many of those convert into a stay in hospital, and we've seen that drop, which gives us confidence that those services are sort of helping contribute to the overall system pressure. But there are absolutely really key challenges that we still need to address to get through in this programme. I think critically in hospital discharge delays. So the target for the programme was to reduce this from an average weight of about 9.7 to a target of 8.1, as it states there on the slide. And we're still not there, particularly in University Hospital Dorset. I won't spoil the thunder of the next slide, but I think positive progress in the west of the county, but still a challenge in the east. Embedding these transfer of care hubs, so a key part of the programme has been setting up for these multidisciplinary transfer of care hubs, which did take us longer to embed in both acute hospitals, and that's partly due to difficulties in staffing, getting the right people in, but also finding physical locations and things like that on the acute sites. But I'm really positive to report that as of October, these sites are live and operational, which is great. And finally, particularly in September, we found some real capacity challenges in home-based intermediate care, particularly in the west of the county, but that was driven by some staffing shortages in both the within the providers, but also in the processing capacity surrounding the providers. So that's been an ongoing focus now. As a result of that mid-programme point, I suppose, gave us a real chance to take a step back and look at where were we, where do we need to get to, and what else needs to change. And we have seen performance improve again. We had a dip after the sort of September, October point, but we have seen performance improve. I guess maintaining that momentum into the winter will be a challenge, but is the goal. And as I said, I think critically where we've seen delays reducing in DCH, now the focus is particularly around sustaining in DCH, but supporting further in UHD and the east of the county, and recognising that we'll need every partner organisation's involvement. It's not on any one organisation to deliver that change. And finally, there have been additional resources invested from Dorset Strategic Partner Newton into this programme, which is in line with the arrangement for this programme. That's at no extra cost to Dorset County. To bring that to life, I suppose, just before I close for questions, I think wanted to call, so obviously names changed, but Penny, I think we had a resident discharged to one of our local authority provided sites, so it's not the community healthcare sites, and actually going into that site, Penny was completely reliant on care, required two carers and further equipment to mobilise. And as a result of her stay within, I think this may have been Coastal Lodge, but I'm not sure, so the BCP site, have seen that actually getting back to full independence and being able to go home rather than going into a long-term care setting or full-time residential care. And I guess this goes back to, if we are able to increase the capacity of those sites, we can see increased volume of people who are able to be supported by those sites, and hence better long-term outcomes for more people. And then secondly, around with Lewis, who is supported by one of our home-based intermediate care providers, of whom there are many in Dorset. One thing that the programme has deployed over the last few months has been a reablement app, so an app that is used by reablement officers on the ground and managers to sort of manage and support the oversight of the care and reablement ongoing within those providers. That's helped Lewis gain more independence again more quickly. And really, so it's not just been us sort of working with teams across Dorset. Actually having our teams out and about with individuals has been really powerful to see. And just a quote there from someone who was receiving reablement, and actually just even having that concept of goals, where am I trying to get to, and being supported through to that, I think was powerful, and their belief and support. Obviously getting some really valuable feedback and insight from those I suppose service user visits that we're then feeding back into our work with the providers of reablement to improve that further. So finally then, I think as it states in the paper, I think really we ask the Overview and Scrutiny Committee to recognise the ongoing progress. We recognise there's more work required to further reduce that average length of stay for people in hospital. That, I think, being the critical measure where we're off track but need to get on with. And with the remaining of time within the programme, there's further work to go around assuring the sustainability of those changes across the system, make sure that it's really important that we deliver in year, but also set up Dorset for future success. And so getting those changes in place fully for the next financial year will be critical for the programme to deliver its goal of supporting Dorset's financial stability. Betty, anything else you wanted to add?
No, not. We'll come in when there's questions, hopefully. Thank you.
Thank you very much for that detailed report. Any questions from any members of the committee? Councillor Salmon.
I just want to check I've understood this correctly. Is this what used to be called the Transforming Urgent Care project that we've signed up to and we're chucking the 9 million across to Newtons for, or is this a different transformation project?
Hi, Councillor Salmon. It's the whole principles around this programme. When you were part of the committee, you would have had the initial programme paper that came, which is all about transforming urgent emergency care. So you're right, within our Dorset system. When we say Dorset, we mean as a county, so we mean BCP Council included. So when Ed was referring to Dorset, most of the time it's the whole of the conurbation across the county. So yes, and that was the setup cost initially, the 9 million that you refer to. So yes, and this is the programme now, a year in its journey, and where we're at within that programme. Does that make sense?
Yeah, so that does make sense. My only worry is I thought the scope of this programme was a lot wider, because reading the report, I don't see anything on RBH Hospital. I don't see anything on Pool. I don't see anything on working directly with SWAST. Although I tell you what, I might be wrong. I don't think SWAST were a partner. I think they were mentioned as a potential partner when somebody was talking about 111, but that's incorrect. SWAST don't run the 111 service. But it doesn't seem as wide-reaching in terms of impact. And one of the things I'm quite worried by is that when the Transforming Urgent and Emergency Care Programme, when that was presented to us at full council, we were told very clearly that no money would be handed over, you know, or payment wouldn't be made until we saw significant evidence of savings. And at the moment, we are handing over more money than has been saved. When you actually look at concrete savings, I think it's 30 grand we've saved and we've paid out £96,000 or whatever. And actually, the way the savings look like they're going to be achieved is just in theory. I don't like the two examples given. If I'm honest, I don't like that I can't see the actual working of this is exactly how we've arrived at that figure. I would like to see that. And I don't like that we're not going to see, it seems as part of this programme, at the end of the 4 or 5 years, here we go in terms of money in, money out. You can see on your bank balance here, look, this budget has reduced by, you know, X tens of thousands, X hundreds of thousands. It sounds like at the end of this process, we may very well be told, oh, this is how much money you theoretically saved, you know, oh, imagine how much worse it would have been if we weren't involved. And I don't think that's good enough. I don't think that's good enough. I don't like that we don't see any movement on the getting people out of the beds back into their own homes. And I don't see in this report how that's going to be achieved. I don't like that I can't see any information specifically on Bournemouth Hospital, on Poole Hospital. I don't understand why they're not in the report at all. Those sites do exist. They're part of the ecosystem. It seems very UHD specific. Maybe I've misunderstood the scope of the programme, and you can come back to me on that. I wish I'd prepared better. I should have emailed you all of this before. But yeah, I'm worried about the bed stay not reducing down, and I don't see in this report what the plan is to bring that down. And I worry that we'll just see in 12 months' time, I'll look at this increase to the number of patients we're sending to SDEC instead of wherever. Theoretically, that's a saving of X, Y, or Z. Oh, in reality, no, David's still got no money to play with. You know, our adult health and social care budget is still incredibly stretched. I think there are significant savings we were asked to make as part of the last budget. I would imagine we'll be asked to make that again in the future. And if those savings aren't being realised by programmes like this, if they're only theoretical, just see things getting worse. I'd also wish we hadn't called it future. Anything in this council called future just, you know, rings alarm bells.
Yeah, so I'm going to let Ed come in and then I'm going to come in as well. But I just wanted to start, before I hand over to Ed, to assure committee, UHD, Bournemouth Hospital site and Poole Hospital site are fully embedded within this programme. They are one of the key partners. They are as much of the partner as what we are in BCP Council, as is Dorset Council and as are Dorset Healthcare. They are the key partners. There's 4 keys, plus with Newton, and of course our ICB, our Integrated Care Board. They are the key partners that form up the future care, and all of the chief exec officers, you know, just reminding you back to the initial setup of the programme, signed up to the programme. So I want just to reassure council that Bournemouth and Poole hospitals feature in this hugely. The whole way through it, I live and breathe Bournemouth and Poole Hospital. Trust me, I was at Poole Hospital only on Friday. I went down to ED and everything to see how this was manifesting within our ED departments. So I'm going to come over to Ed just to talk about some of the financial and some of the data, and then I'll come back in if need be. Thank you. Sure.
Thanks, Betty, and thanks for the question. Yeah, wherever in the report or where I was talking about UHD, that is both all data aggregated Bournemouth and Poole hospitals. So all of the work ongoing within UHD is working with staff, clinicians, colleagues within Bournemouth and Poole, and all supporting staff around those sites as well, just for assurance. On the savings and particularly, I suppose, the transaction and financial realisation, I suppose I'll treat those two separately. I think there is a ongoing sort of every month finance benefit working group that has each of the partner organisations represented, and that report is provided monthly to all chief CFOs and Section 151s for the local authorities to assure them and support them in transacting the benefit to genuine, I suppose, cash out as in line with the original business case. So that scrutiny, I suppose, is absolutely there, and I think I'd concur with the statement of that needing to is not enough just to have the theoretical savings. It has to translate to the realisation. I suppose I'd look to others to, if that's something to be brought to a further committee and board to report on that. I know it's something that is regularly reported on. I believe, off the top of my head, the number for the in-year saving across the whole of the system is on target for 6 million within this financial year. Obviously, that's split across all organisations. I wouldn't talk to each one specifically, so significant saving in year and then further savings predicted for the next. And then, I suppose finally for the comment on ensure it sort of in 4 years' time and where we get to. I again completely agree that I think we need to be able to and would be happy to go through any of the calculations in detail with anybody who would be who is interested, but needing to get to and have the level of specificity on, well, for instance, track through to, and I have regular conversations with Betty's finance colleagues about how do we, rather than just tracking a number, how are we making sure that we're able to track through to actually it's 5 more people have gone through this service than would have done last year, and those people have had a more effective stay. So I take reablement as a specific example, and therefore we have seen fewer home care hours being procured, and how do we match that through to the budget setting? And I suppose my final point is just to comment and bring back to on UHD specifically, where I said, and again, I draw a link to the sort of the length of stay that I talk about as definitely being the key challenge, and that's really, I'd love to come back to this to you in a few months' time and actually say that the waste of the programme focused on actually let's bring that number down. What gives me confidence is we have seen the number coming down in Dorset County Hospital through the same model and approach. We're slightly behind in UHD, where I recognise that, but that's where the focus of the programme is, and how do we bring to bear all of the energy on that. But I would say that positively we've seen a reduction, or rather an improvement in the outcomes of those individuals. So although the length of stay hasn't shifted yet, we have seen a reduction in the number of long-term of people going straight into a long-term residential stay, which I think is positive, even though we still have work to do around the length of stay within the acute hospital.
So just picking up from that, if we were to look at this again, say in the spring, would it be possible to have the kind of data analysis that Councillor Salmon have indicated, both in terms of the money in and out, as it were, but also more importantly, I guess, the impact on individual residents and those using the service? Would that be doable?
Yeah. Oh, sorry.
Yeah, no, that would absolutely be, and I would be surprised if committee weren't asking for that, because we're so far into the programme now. So I would, that would be something I'd really support committee with requesting. I think, Chair, if it's okay, I just wanted to kind of put a bit of reflection onto some of this with regard to those key work streams that are on the presentation that you that Ed showed. The alternatives to admission is very much centred around Bournemouth Hospital, Poole Hospital and Dorset County Hospital. They are absolutely about what do we do with people who don't need to come into those acute environments but need something. And it's about how are we kind of picking those people up early enough. But even if they get to the front door of any of those ED departments, how do we turn them around to the right environments without putting them through hospital wards that they don't need to go through? And then, and it's not a nice environment to be in if you don't need to be in it, if you're not really clinically unwell. And that's where the same day treatments, you can be triaged through the same day treatments, where we're seeing an increase in the number of people going back to where they came in from, or being able to access one of our discharge to assess beds that fall within the programme. And they can either be a Dorset County or a Dorset healthcare bed in a community hospital such as Alderney or Wimborne or you know, those kind of beds, or it can be one of our beds in Coastal Lodge or or Figbury Lodge. So, and then it's about our reablement service as well with Tricuro and our reablement service with Care Dorset, because this is the whole of our county's population. And I think one of the key things, and just coming back a little bit on Councillor Salmon, we are beginning to see a reduction in the length of stay in pockets, but it's not consistent throughout. And that's why we still have a no criteria to reside number that is higher than what we would like, particularly in our acute environments. But that length of stay is being reduced, and you could see that on the slides where it was beginning to reduce, reduce down, and we needed to reduce further down. And by reducing down the length of stay, then you're able to get more people through the front door. So you're able to get, if the back door is working well of a hospital or whatever environment, then the front door can take more, and that's what it's about. So in its totality, I guess I would say this program is so fast. It has so much going on within it, but we are beginning to see the green shoots of it, and the money, certainly from a BCP council perspective, the money is already taken within the MTFP. So it is in theoretical money, and it's not, it's not money that isn't actually going to be coming out. It is actually factored into the MTFP, but it is an invest to grow. And that's where the investment came from. And what I would just finish with is, if we didn't have this program, our demand has gone up hugely, in some areas by 17 and 19%. If we didn't have this type of program, we would not be able to manage that increased demand and sustain everything else that is already running. Adult social care is one of the biggest departments, areas within a council, and the bigger number of population going through it. So we need to keep changing and evolving to be able to meet those changing needs of our population. Thank you, Chair.
Thank you very much. I'm just going to take any further questions before I move on to the recommendation. Councillor Salmon.
I just wanted to say thank you for both responses. I know I sound very critical. I don't mean to. It's personal, and I think lots of people are working incredibly hard on it, yourselves included, and everybody else. And I think you're absolutely right about the need for transformation. It's just that I think the transformation program was always going to be hard to get right, and I think as a committee we do have a duty to be very critical. Very not cynical about improvements, but skeptical. And I do recognise that Newton's probably in a hard place where if they just went, oh, look, your budget's gone down by X million, we'd go, oh, well, we were going to do that anyway. They've got to also go, oh, this is how we'd have done, this is, how we saved it. Hasn't happened in practice. I'd still stick to my original position, which would have been to not involve a third-party consultancy from outside and lean more on our expertise and upskill within organisations like the DICE. I just wanted to check on one other thing. There is the mention of community hospitals. Does that include the Dorset Healthcare run community hospitals as well?
They are the only community hospitals that I know of in our county. We have we have 13, but 12 really that are functional community hospitals throughout Dorset footprint, and they are all managed by Dorset Healthcare.
And we're absolutely rock solid on that 36-day average, dropping down to 31.
Yeah, and there's an intention to further reduce the length of stay. And if I'm being really objective about it, that is not that is not an unreasonable target. People stay ready to kind of go to their next journey and their more permanent journey. And sometimes it takes too long to enact whatever it is that's needed to enable them to move on. So I wouldn't say that is an unreasonable length of stay. It's just we need to make sure that our infrastructure around that is sustainable for the longer term. Otherwise, all of what you said could become the reality.
Okay, thank you very much. Thank you, everybody. So the recommendation is that the committee recognises the progress that the programme continues to make in respect of improved outcomes for people and the delivery of financial benefits to the Dorset integrated care system, but that more work is required to reduce the average length of time people spend in hospital waiting for a care package. So that's the recommendation. But what we'll also do in addition is we'll bring this to the next committee meeting in the spring and ask those that have the information and data at their fingertips if they might be able to help us a bit more at that point. Is everybody content with that? Thank you very much. Okay, moving on to item 9, integrated neighbourhood teams. And you may recall that this was on our list of proactive items to scrutinise. So I'm pleased that we've got with us, I think we've got with us anyway, Dawn Dawson, who's the Joint Chief Nursing Officer, who I think is going to introduce the report. And we also have Judith Dean, excuse me, Judith Dean, Transformation Director, and also Dr. Lucy Knight, who's the Chief Medical Officer for Dorset Healthcare. So over to you, please.
Thank you very much indeed, Chair. So as described, my name is Dawn Dawson. I'm here this evening representing Matthew Bryant, who's our Chief Executive, who can't be with us. So I'm going to give you a brief introduction, then I'm going to hand over to Judith, who you've said is our Transformation Director, and we're hoping Lucy Knight's going to join us. She's not actually on the call yet, but I believe she'll be with us very shortly. So work in Dorset started some time ago on this agenda, and it's absolutely critical to enable people to live well and independently in their communities for as long as possible. And in doing so, that will enable us to make the optimum use of the limited resources that we have available in statutory services, both within health and care. So Judith's going to give us a short presentation, and she's going to talk a little bit about the 10-year plan and neighbourhood health. And then if Lucy's joined us, she'll pass on to Lucy, who can pick up on progress since we've become one of the 43 national pilot sites for their neighbourhood implementation programme. So I'll hand over to Judith to start us.
Thank you very much. I'll just load the presentation and tell me if you can see that. Are you able to see that? That sharing?
Yes, that's great. Thank you.
Okay, perfect. All right. Thank you very much. So, as Dawn says, the INT, the planning for the programme, probably started about 18 months ago. And it was seen very much as a core component, but not the entirety of the work to improve health and well-being across the system. The focus very much on developing local teams of people who working together, building that confidence and autonomous teams to work around the needs of the population. There's lots of different ways of developing integrated neighbourhood teams, but there's really overwhelming national and international evidence that if you start with the teams themselves and support them to work together locally with their population and to remove some of the barriers that get in the way of them working together, can be some of the most effective ways of delivering the outcomes the system is looking for. So we have a logic model that sits behind the benefits case, the change methodology, and the metrics for the programme. And so what this starts with is saying that actually, if you bring those teams together and those teams get to know each other and feel have a common purpose and a shared responsibility for the community which they serve, those teams then can come together and start supporting those individuals in a more integrated way, really enhancing the quality and experience of cares for those individuals who are currently using multiple services, reduce duplication between health and care practitioners to start creating and releasing some capacity, but also starting to reduce demand for unplanned health and care services. By reducing that demand for unplanned health and care services, this starts to free up resources to be able to increasingly focus on those people who've got ongoing health and care needs and rising risk, building the knowledge, skills, resources and confidence for those individuals to take better care of their own, their control over their own health, That in time then reduces further the need for health and care services. That allows us then to start moving money and resources from hospital into community, from treatment into prevention, and gives us the ability to start tackling the wider determinants of health. And I'm sure I don't need to tell you that that final step is really important in terms of sustainability, as whilst the responsibility for managing much of the current demand is falling within health and care, the addressing the root cause is often not a health solution at all. So tackling those wider determinants of health is key to building those healthier, thriving communities. This is not something that is new. Even when we started this programme, it's a journey that BCP Council have been working on for many years, and the NHS as well, looking at integration. And when we started, though, we realised that health had got an awful lot to do. We've got fragmented services, siloed services. We've got our own teams working in buildings with people who didn't know each other, lots of duplication. And so what we realised is that we needed to get health house in order, for want of a better word, to be able to work more effectively with partners in that integrated neighbourhood space. So we did start by building the neighbourhood health teams element of that. We've now got, so we started by looking at using GP practices as the building block for integration. GP practices tend to have the most comprehensive health and social care data. People know which GP surgery they belong, they're registered with, and we can go some way towards mapping them to local authority wards. So the starting point, we took a pragmatic approach and rolled GP practices up into PCN footprints to get us started. There are 9 integrated neighbourhood teams across the BCP footprint. As I say, we did start with health, but now all of the 9 teams have also got an adult social care representation on the leadership teams of those. And the next step is to include people and communities representation. So each of those teams have been looking at building those relationships, streamlining systems and processes, particularly where multiple teams are looking after individuals. And we are systematically looking at how do you address the barriers to integration. So we know that there are currently challenges around data sharing, the fact that the teams need to refer to each other, and it is consuming quite a lot of time for individuals that's not adding value to those patients. And importantly, with the programme, this didn't the funding for the programme didn't allow us to build new capacity. So creating that capacity for teams is really, really important. We managed to get the business case approved by the Integrated Care Board in May of this year. Unfortunately, there wasn't funding available in the system, so we have been successful in looking at securing external funding from Macmillan through a social financing route. And we are really beginning to benefit from Macmillan's approach, not just in terms of their funding, but some of their support that they're giving us with this. So some of the INTs are still building the teams and looking at internal processes, and what I've put here is their improvement processes, where they're looking at those areas where they work, where many different teams are working with individuals and looking at how they streamline those processes. But others are also at the stage where they're starting to work with communities. So we've got some just beginning to make sure that people know who's who in their neighbourhood, and also supporting upskilling care navigators to make sure that they can signpost. We've got North Bournemouth, who are starting to engage more directly with community groups to engage in social, physical and mental health. Central Bournemouth working to engage with individuals to understand what immigrants' access needs are. And in Christchurch, proactively reaching out to those people not in recent contact with health and care. But there is lots more to do. At this point, I was going to hand over to Lucy. Has Lucy joined the call? Brilliant. In which case, I'll hand over to Lucy.
Hi everyone. So I'm Lucy Knight. I am the Chief Medical Officer at Dorset Healthcare, and I'm leading the programme for Dorset Healthcare, the neighbourhood programme. I'm also an old age psychiatrist. So Judith has talked you through the sort of first stages of the programme, and I'm going to talk now a little bit about the national picture. Because earlier this year we had the 10-year health plan, the NHS 10-year plan, and that outlined 3 core shifts that they want the NHS to make. The shift from hospital to community, from sickness to prevention, and from analogue to digital. And they were very clear in that plan that a large part of this is to be delivered through neighbourhood health. So neighbourhood health is a slightly broader term than integrated neighbourhood teams. Integrated neighbourhood teams are a core part of neighbourhood health, and I'll talk to you a little bit more about that, but just in case there was any confusion in your minds over the 2 terms. And quite shortly after the 10-year plan was published, we had a request from NHSE to apply for the National Neighbourhood Health Implementation Programme. It's not a particularly snappy title. We now call it NHIP. And all systems were asked to apply for that at place level. So the places in Dorset are BCP Place and Dorset Place according to the local authority footprints. So we made an application from both places in Dorset, and Dorset Place was successful in wave 1 of the National Neighbourhood Health Implementation Programme. I'm going to tell you a little bit about that, and then Judith, are you able to move on? Slide? Are you in charge of the slides? Because I could share, but are you all right just moving it on when I ask? So the wave 1 of the NHIP is led by someone called Dr. Minal Bakal. She is our new heroine because she's absolutely incredible. And she wrote an introductory document, and we've got a couple of quotes from that here. So it's about a radical shift in how we approach healthcare, not just a new model of care, but a fundamental overhaul in ways of working and thinking. At its heart, moving from institutional power to community power, asking what matters to you, doing with, not doing to. And it focuses quite a lot on shifting the power from large NHS institutions to communities, which I think we all feel is we're really ready to do that, and it's time to do that. We should be really focusing on that as much as we can. So what we did after that was over the course of the summer, we've been really shaping up with the new investment, the leadership structure for our neighbourhood health programme. And this diagram here has become known as the eyelashes. And you'll see the slide after this is a different view of the eyelashes. But this gives you an overview of the leadership structure, which really is as flat a hierarchy as we can have while still having enough direction and leadership in order to make sure that we're all moving forwards together in a unified way. So it's really important to us that although Dorset Place is in wave 1, that the benefits that we see from that are shared and mirrored in BCP Place. And you'll see this structure is an exact mirror of both parts of the county. So at the top of the structure, we've got the green overarching lead boxes, which are the leadership team. Then on either side under that, we've got the blue place boxes. So we've got Dorset Place, which has a quadrumvirate leadership model and a supporting leadership team, and the same for BCP Place. And then all of the individual neighbourhoods, which is the purple eyelashes, are all the individual neighbourhoods, which are all absolutely fundamental to the programme. And each neighbourhood has a quadrumvirate leadership, which Judith was talking about. So we have a primary care lead, a Dorset healthcare lead, a social care lead, and we are looking to develop people and communities representation in the leadership team. There is also mental health input to those leadership teams. And what I want to draw your attention to now is the big yellow box in the middle, which is our co-production group. So we have 2 co-production co-leads, becomes a bit of a mouthful. Becky Aldridge, who is from the Mental Health Forum, and Phil Morgan, who is employed by DHC. And he is our Associate Director for Neighbourhood Co-Production. And that group is incredibly vibrant. It has a really fantastic representative membership from charities and the VCSE across the county, with a strong voice from BCP in there. And we're looking that their task is to hold the whole programme to account for co-production and for making sure we do the right things. So the next slide shows you the different groups that are at play here. So right at the heart of, again, you can see the eyelashes. I think this looks a bit like an ostrich head, which always makes me feel slightly happier. Down the centre, those groups down the centre are the groups that are in place, which cover the whole Dorset and BCP area, because there's an awful lot of national guidance, and there's a lot of things that need to be similar or standardised across the whole county, or we'll end up with a load of duplicated effort in both parts of the county. So we've got our core groups down the centre, and then the 2 blue circles on either side are the neighbourhood health implementation groups. And you can see there's one for BCP, one for Dorset Place, and they all relate to their individual neighbourhoods. As part of this programme, we've had quite a few questions about what is a neighbourhood. And there isn't a lot of national guidance on this, and that the NHSC is publishing and producing the models over time. But at the moment, we're on a promise that there will be a neighbourhood health model due soon from NHSC, but currently there isn't anything to really guide us clearly. And so this model that you've got here, the green box, which says My Neighbourhood, is our attempt to use what's available to pull together the thinking. So it's got 4 core components here, which are all overlapping and very closely linked around the people in the neighbourhood. So you've got your local health and care team, which is the core integrated neighbourhood team, the INT. Then we've got input from specialist health and care, which would be from the acute hospitals. And then we've got the wider sector and the voluntary sector, and then we've got the community itself. And that comes together to form the neighbourhood. And you can see there's an explanation for that in more detail along the side there. One of the things the national programme has been very clear with us about is what they want us to start with, what they want us to measure. So we've got a very clear focus that we have to follow, and it's quite narrow in the first instance. And that is because it's such a big programme that you need to start somewhere and get something right. And on the left here, you've got the diagram that comes from the Wave 1 NHIP paper, which shows how they see neighbourhoods developing over the next 5 to 10 years. So it's starting in quite a small way with NHS and social care coming together, although we've already spread it a bit wider than that. Then the next stage is to strengthen the primary and community-based care. So that is really looking at providing more support for people to be at home or closer to home. And then finally, the third stage is to work in a totally integrated way with social care, public health and other services, including the third sector. That's their first go at describing it visually. I think what we're hoping to do is to start in the small focused way, but to include those other component parts from the beginning so that we are shaping things in the most correct way that we can. So this triangle here on the right demonstrates and describes where the focus needs to start as described by the national programme. So to begin with, they want us to focus on individuals who are spending time in health care settings and social and care homes that isn't helpful to them. So people who are high users of services where those services are not benefiting them. And we all know that there's a lot of people who are in acute hospitals who are ready to leave, but who, for whatever reason, are unable to leave in a timely way and end up spending their precious time in a place that they may well not want to be in. And the next stage of focus is to look at individuals who are at rising risk of spending unnecessary time in hospital and care homes. And so these folk are people where there are some markers which, if we can pick them up, will let us know and inform us that they're actually at risk of going into the top of the pyramid. But currently, there's probably work that we could do to prevent that from happening. So on the next slide, this is the slide you saw earlier where Judith outlined what had happened at the beginning of the programme. So we have now moved into this next stage, which is looking at people who are high users of services. And we have been able to identify those using our Dorset Information Service, which is our population health programme. So this programme was started earlier in the summer, and using the factors that are outlined here in the little circles, we were looking for people who had more than 20 GP appointments a year, 5 or more ED attendances, and 3 or more emergency admissions. And using those criteria, we identified 419 people in the BCP area who were using services at that level of intensity at the moment. And the DICE programme is able to send the information about those individuals to their relevant GP practices in an anonymised way, and the GP practices can then decode that information and find out who they are and start to work with them. So those people, the 419, on the next slide, it shows you how much healthcare they've been using. So 15,000 GP appointments, over 3,500 ED attendances, and over 2,000 emergency admissions. And that nearly half of them are also using social care services. So they have a really high service use. And what we found when people have de-anonymized the data is that for some people that is unavoidable, and it is right for their stage in life and for their circumstances. But for other people, it could be avoided, and they could be having a better experience of health and social care services. So we've been developing a care and support framework, which is to help us assess and manage these people's experiences and use of healthcare service better. So it's a framework that has been shifting the conversation from what's the matter with you to what matters to you. And during that, it's often apparent that the drivers of health service use are social issues, loneliness, and other factors, maybe depression or anxiety. And actually, the way that the health services are being used by these people are actually not benefiting them. So using the wider range of teams and services in the neighbourhoods, we are working on a person-by-person basis with these 419, with the intention of them moving later to the rising risk group. So we're all very excited about our neighbourhood health programme. There will be a lot more to come. I'm very happy to answer any questions or have discussions, etc. I can see myself twice now.
Thank you very much indeed for that. I think you indicated at the start of your presentation that you might be able to help us with how this relates to the more recent government initiative around neighbourhood health centres and what was announced in the recent autumn statement. How did those two things link?
At the moment, it's not 100% clear. There has been in the neighbourhood, in the 10-year plan and in the first wave, there's been talk about neighbourhood health hubs, and there being buildings and centres either at multiple neighbourhood level or individual neighbourhood level. But there isn't the detail around that at the moment. we're obviously looking and tracking our estates quite carefully to look at what we've got available, both in the individual neighbourhood levels and at place level, in order to be able to deliver more local services through the current estate that we have across the whole sector of health and social care.
Yeah, I get that, but the autumn statements are quite specific in the number of these new neighbourhood health centres that were going to be agreed. And what I don't know is whether we're going to get any of them in either Dorset or BCP.
We don't have that information at the moment. Not that I'm aware of. I don't know, Judith, if you're aware of that, or other Judith.
No, we don't have that yet. And I think nationally they're looking at 50 nationally, so across the entire country by 2027 or something. So we are waiting with that. I think, though, there is still definitely an ambition to look at co-location and kind of how do we bring services together locally. So we're part of that national programme. So we will have the opportunity to influence to see whether or not we can get on the front foot when they are announced.
Okay, I'll open it up for questions in a minute, but could you just help me with one other thing? There was mention in your presentation about the involvement of the community. I'd like to understand what that means. And where do the users of these services fit into that equation?
So at the moment, the co-production group are working up a plan for involving the communities more closely in the neighbourhood leadership teams. What they're really keen to do is develop their group and their relationships, and to do the work at a pace that means it's sustainable, and the work that they set up is able to influence in the way they want it to. So I'm hesitating because they are still working the plans up for that. But they are very determined that they want to do it at the pace that works best for them.
At the pace that, when you say them, who do you mean by them?
Well, the co-production group and the people that they are going to be linking up with. So they're developing the plans for how that's going to happen.
Okay, thank you. Any questions from anybody in the committee? Councillor Northup.
Sorry, keep doing the wrong one. A lot of what's in the report is really familiar because we've had things like this before, I think, and I wonder if we have got learning from what's happened before, because in my mind I can think that we had a whole Darcy Centre built in Boscombe, built and then shut down over a 10-year period, and now is not functioning. And it was built with absolutely all of these things. It was built to be a GP place, a place where you can go and do like yoga upstairs with special rooms and everything. And it's just ticks all of these boxes. But for some reason, it didn't even last 10 years before it was repurposed into the sexual health centre. And now we almost seem to be talking about doing all of the same things again. And I feel like some of the other things that have been talked about, like identifying who's high users of A&E, is certainly something I recall happening not maybe 10 years ago again. That I know my surgery does that, and they talk about that, and they have posts on the wall about it. So do these things happen and then stop happening, or I just wonder if you can comment on making sure that we don't just keep making the same actions and spending a lot of resources doing the same things over and over.
Yeah, and I think it's a very fair question. We have had that conversation. There are some differences. I think that there has been steps forward and then steps back and steps forward in this area for many, many years in health, and I've been involved in multiple campaigns and processes. There was another one about putting GP surgeries together with other, I can't remember what the name of the programme was, in multiple, into buildings, multiple services. So first of all, I think we are gradually creeping forwards. So I think there has been forward momentum, although it has been forwards and back. But the main difference now is that the NHS 10-year plan, this is the first time we've had a national programme plan that has said this is what we're doing. So the previous NHS long-term plan really talked mostly about acutes, a little bit about mental health and very little about communities, whereas this 10-year plan is really all about neighbourhoods, and that is a significant difference. So the national direction is much more determined in this way now, and there is a lot of work as well that's been, or the work that's been happening previously, the bits that have not stepped back, we've got stronger foundations for it. When it first really started, sort of about 10 years ago, it was a completely new way of working, and we have gradually built up some foundations. And so I think this time there's a much stronger commitment nationally to this direction of travel, and we've got better foundations to make it happen. No doubt that there is, and you may have noticed, NHSC and the Department of Health and Social Care, that this year has been a year of some quite unexpected and sudden announcement, rapid changes, and a lot of things we're being told to do where there is not really very much detail available to deliver it, and the details coming later. So we're having, so for things like the neighbourhoods, we were told to do it, and then, but we haven't got the neighbourhood model yet. So I think there's still some unpredictability to it, because the national picture is quite sort of unpredictable in itself. But I think the 10-year plan sends us in this direction, and I think it's more likely to succeed and sustain because of that.
Thank you.
I don't know whether Judith or anyone else wants to add to that.
Thank you, Councillor Dower.
Thank you, and I must concur with Councillor Northover about the fact that if you're in an organisation long enough, you see the same things coming around again. So mine, all my questions are about data, because I mean, what we are presented is really good and it's really interesting and helpful, but I haven't seen anything to see what's the baseline of the cost, what are we spending at the moment, and how is that going to be saved, and how are we going to measure the success of how this is going to happen. The only thing I've actually identified was about these 419 people. And out of the whole of Dorset, that's a very small number in my head to spend a lot of effort on, if it's not going to see any financial savings. So I would like to know the cost of all those health services. So you saw there was a slide with all the health services that these 419 people have used over the past year. So what is the cost of that? How much does that cost us? And what are we going to do to change that? And what are the savings going to be as a result? So that's just that 419 people. So then what is the bigger picture of, this is my business analyst head. I'm looking at costs and data and I want to see it. And I can't see a lot of this in this presentation. So I'm sorry if I've been a bit picky there, but I think it's really great and interesting, but I just think that's what's missing for me. Thank you.
Judith, did you want to speak to that?
Yes, I can do. And apologies, it isn't in the presentation. And one of the reasons it isn't is we weren't able to kind of like separate it out to the BCP part of it. The programme has identified a range of savings, some cashable and some not, so some around productivity. Over the 2 years of the programme, we are expecting to see a reduction in cashable, so money that we can take out of other services, of £6.3 million. I'm quite happy to share with the committee the kind of makeup of that. But we are tracking very hard the difference that we're making with those. And that also links back to the Macmillan funding agreement with that. So if the programme is not delivering those changes and those savings that we are predicting, then what we need to do is to reconsider what it is that we're doing to make sure that we can deliver those, not just keep making changes that aren't having the impact.
Can I come back on that, Chair?
Yes.
Yeah, that's great, but I still need to know what how are we going to evidence those savings? And I'm sorry to keep pushing on that, but I think it's quite important.
No, that's, shall I come back? So yes, what we do within the programme is so there's 8 areas of savings that we're expected to see. So they're around unplanned admissions, length of stay for unplanned admissions, emergency department attendances, outpatient referrals, elective referrals, spend around prescribing, spend around community equipment, and one other which I couldn't remember. And we track the activity against those across the whole of the system. And we're able to, what we've done is to project a do nothing forecast with it. So if we didn't do anything, using 3 years worth of historic data, we projected what that activity growth would look like. We've then plotted the expected demand against demand reduction against that, and we're plotting that activity on a monthly basis across all of those providers. So we look at that element of it, and that's how it links back.
We can share more slides with you because there is a lot. There's a very clear direction nationally about what we have to measure, and we've actually got in Dorset one of the best population health measurement systems in DICE. So we're tracking it all. We're able to see what's happening, and every month we're producing a report with changes. We've only started that in August, so it's a bit. September was our first month of data, and so we're not expecting to see significant changes so far, although they have been surprisingly positive even just at month 1. But it's all there. We just haven't included it in the pack, but we're very happy to share it. You could see the program board dashboard the dashboard that goes to program board. We do have, I think, some of the best information in the country because DICE is such a great program.
Fantastic. I would be really interested in seeing that, Chair, if that's all right.
Yes, is that something you would be able to share with the committee, that information and that data?
Yes, absolutely.
Thank you. That would be really helpful. Thank you very much indeed, and we'll pick that up in due course. But thank you all so much. I'm just going to do the recommendation, if I may, because recommended that the committee note the progress made on developing integrated neighbourhood teams. Is there anything else anybody wants to add to that? Okay, everybody. Okay, well, thank you again, everyone, for helping us through that, and we look forward to the further information when you feel able to share it. That would be wonderful. Thank you very much indeed.
My pleasure. Good evening.
Okay, we're going to move on to item 10, which is the Dorset palliative and end-of-life strategy. And again, this was something that was on our proactive list of items to scrutinise. And I think we have with us Judith Westcott, who's the Deputy Director of Integrated Neighbourhood and Primary Care for NHS Dorset. I hope that's right. And Claire Galley, who's I think the Chief Executive of the Lewis Manning Organisation Hospice, to present this item. So I'm going to hand over to you, please.
Thank you so much for the invite, and I recognise we come at the end of a busy schedule today, so thank you for sharing the time with us. As you can see, I've come with Claire, and I think it's really important that you are able to hear this presentation from both Claire's perspective and my own. Thank you as well that I've managed to sit through the last 2. I'm the lead commissioner for the integrated care programme that Judith and Lucy have just been talking about, and I think it's really helpful that you've had that, because the end of life work is very much, if you like, a sort of a subset and is following the same direction of travel as the INT programme. So we're working on looking at how we bring end of life care into the community and ensure that people can come to the end of their life where they most want to be. I've got a short presentation that Claire and I are going to do, so if that's okay, I'll share screen. Please do let me know as soon as you can see the screen.
Okay, we have that. Thank you very much.
Is that coming up for you? That's lovely. So we will just go through these slides. They're just to help Claire and I to be able to talk through what we wanted to share with you. So just to go back, I have to say I've only been with Dorset and NHS just over a year now. Beforehand, I was working in Bath and North East Somerset in the council there, working alongside the NHS. So it's been a sort of move across for me. But that does mean this programme was started prior to my tenure here. But so I'm talking about things that happened, I think, started in 2020. It was a really important programme about trying to think about how we could move on, and started with a whole range of consultation with people in both BCP and Dorset areas, talking to them about what mattered to them, about what was happening as they came towards the end of their lives. They set up a steering group. They spent much time thinking about what was relevant and what was important to them, and they came up with the strategy that you now see before you. The strategy looked at 7 key areas that the people of BCP and Dorset talked about as being important to them as they came to the end of their lives. So as you can see, that joint working, which obviously there is that link across to INTs, was one of the first things that they spoke to us about ensuring that social care and healthcare and that which was offered through the voluntary sector was all coming together in one way. And again, talking about that, how we have joined up that work to more effectively move that care supported forward. You'll then see that there was a lot of conversation about where people were as they came to the end of their lives, and that they wanted more opportunities to be in their community at home with their family as they came to the end of their lives. They talked too about wanting to know about more education for people so that anybody could help them as they looked at some of those areas of health and social need as they came to the end of their lives. And then obviously about bereavement care for their families, and wanting to know that those people who they left behind were having the care and the support that they needed. And of course, helping those who are caring through that time is vitally important. And you'll be well aware that as we've taken forward virtual wards here in Dorset and BCP, it's been an important strand of work to work closely with our carers activity to ensure that carers feel comfortable with having people who are sicker than they might ordinarily have been in a home setting. It has worked well, but there's continuing work needed. And then, of course, that continuing feedback, which links us back to what Lucy and Judith were talking about, of putting carers and the people of Dorset and BCP at the centre of all our planning. We've kind of got the strategy, and the strategy was agreed and was signed off in December last year. So I want to talk to you a little bit about the work that Claire and I have then been taking forward. What I realised very quickly was that we needed to work in collaboration, just as the people had said through the consultation, to move forward. So Claire and I were able to put together a group of about 7 or 8 providers and stakeholders from across Dorset and BCP to talk about how did we move from good ideas and the strategy to moving that forward. We had some really helpful ideas, creating a theory of change, trying to understand how do you actually change things practically. And you'll have just have heard about how INT have drawn some funds from Macmillan for social investment. And we've also got an offer on the table from Macmillan for this programme too. So they're prepared to support us with a further 4 million over the next 3 years to move forward this as well. And clearly we've had the benefit, as Lucy was talking about, of the 10-year plan, which, as she says, for the first time is really putting weight behind community care. I've waited for this for so many years to actually hear how important it is to support people where they're at. And you'll have heard all about that activation methodology, which I think is absolutely critical to what we're doing here and in the INT programme, which is enabling us to understand that people who are in charge of their health, their lives, their well-being to the greatest possible point are those who actually thrive best. And I think that's a really important part of both of these programmes as we move forward. So what we did as we worked together, we looked at the 7 points, and it felt like that these were the 3 areas that we should focus on with the funding that we might have available to get to a point where we could sustainably take this forward. And it's really important to note, and Claire will talk about this a little bit more, our hospices have had a really rough time, and the way the National Insurance Programme has come in has made it really difficult for them to take forward their values, their ambitions, and all the work that they wanted to take forward. And therefore, we've tried to think very carefully about how we support our providers as well as we move this forward. And we felt that these were the three areas that would really be something that we here in BCP and Dorset could do, as well as what would be the right thing for the people who needed these support services. So the first thing that we talked about was this single point of accessible help through the year. So you'll be aware that at the moment you can phone hotlines for emergency and urgent care, but they don't necessarily have specialists available around people at the end of life. So what we want to do is to bring alongside them this specialist phone line, which will enable anybody who's coming towards their end of life or their carers to get immediate help and support about what they're worrying about, what they're concerned about, and that they know that they will get expert support and advice in the help that they need in that space. We then wanted to talk about advanced care planning and case finding. As we were just talking about, DICE has got some amazing details in it. And what it basically shows is the data is very clear. If you don't have an advanced care plan, you are something like 4 times more likely to go to emergency departments than you are if you do have an advanced care plan. If you do have an advanced care plan, you will look towards your GP and other local community settings to support you in your care. And the number of people who come to their end of life at home is significantly higher amongst those people who have an advanced care plan. So one of the first things we wanted to do was to increase the number of people who had those plans. It's a very straightforward thing that we can do and something that we can do together alongside and through the INT programme. And then we also wanted to ensure that when people needed help, they could get it fast. So it's not so much, we use the word crisis intervention, but it's more a matter of being there fast. So if you're worried about your mum or dad, or the person coming towards their end of their life and thinking, what I want, I don't want to do the wrong thing. Should I be taking them into hospital now? But if we can bring care really quickly, all linked in with those integrated care records and advanced plans, we can ensure that everybody gets their help immediately, meaning they don't have to go into hospital. I think it's deeply saddening, and I know Claire would reflect on this too, the number of people who come to their end of their life, and then in those last 24 hours or the last 3 days, we have to take them to settings where the family can't be with them all the time, they don't have access to their pets and their home surrounding and all those things, which make a sudden jolt in their lives when we want to be able to support them to be able to go smoothly onwards to whatever is next for them. So those were the 3 areas that we're looking at. And obviously that's linking through to our INT programme, supported by the Neighbourhood Health Service. The recently announced palliative and end-of-life modern service framework, I think, is also going to give us some grist behind the wheel. And the support from Macmillan, they have been absolutely brilliant. Alongside the INT programme, again, they're bringing us such creativity and support and helping us. So you'll know that from this, it's exactly the same as in the INT programme. We are looking for crunchy changes at the end. We will make left shift. We will reduce the amount of activity that happens in acute settings. We will increase the activity that happens in community settings. I kind of want to hand over to Claire now. Claire, first of all, please do come in and say any of those things about the slides that we've looked at. But Claire would really like to share with you now what this will mean for the people of Dorset. So a lot of this is about sort of the high level changes, but we really wanted to bring to you what we think this will mean to the people on a day-to-day level. So Claire, I'm going to hand over to you.
Thank you, Judith. And first of all, I'd just like to say how much Lewis Manning Hospice Care has enjoyed being part of this programme and being so involved with it. First of all, end-of-life patients and carers are often unaware of the likely trajectory of their condition and how to manage those challenges to their health and well-being in line with their preferences. And that's really, really important. Patients don't get the opportunity to confirm their preferences before they deteriorate and then end up in hospital. And we see it an awful lot at Lewis Manning Hospice Care and while working with other hospices. And there's limited awareness of the options open to patients, including what they can do for themselves. And that empowerment of patients and their carers is so important. A lot of it is about anticipatory care, and as Judith alluded to, about advanced care plans. Some patients and carers become really, really worried about decisions to stay at home at the end of life, even though they may well have decided that that was the best thing that they wanted at the time. And this can result, certainly when somebody starts to deteriorate really quickly, into hospital admissions. And it would be remiss of me not to mention that high quality palliative care in Dorset is very inequitable. There is a lack of government funding for hospice care, and Dorset's also in the very unusual, particularly East Dorset, in the very unusual situation of having 3 hospices. And this is a great opportunity for those hospices to come together and work much more closely together, working in collaboration and partnership, as opposed to in silos, which has certainly happened in the past. So I wanted to talk to you about Jill, who's a carer for her husband, and this is something that happened 2 weeks ago that we were involved with. Jill and her husband are both in their 80s. It's Jill who has advanced terminal cancer and actually has outlived her prognosis to date, but she's caring for her husband, who's also in his 80s. They have a twice daily visit from a personal carer, and apparently they're on the waiting list to get a carer's support. But Jill is her husband's main carer. She's quite fit, and actually, if you met her, you wouldn't actually know there's anything wrong. She's a carry on and keep calm and carry on sort of a person. And they have children who live abroad, so it's just them. Jill's patient history, there was a diagnosis of cancer, advanced cancer at stage 4, had a bowel resection with colostomy. It metastasized and she has lung nodules. She came to us for breathlessness support initially, was discharged from oncology into specialist palliative care team at a different hospice, but with a poor prognosis. And she had a DNA CPR, but no anticipatory care plan. And in August, she went into hospital for her first hospital admission, and that was related to breathlessness. Judith, if you could. So Lewis Manning Hospice Care had the referral from the PCN coordinator, and one of our nurses visited both Jill and her husband to discuss the referral and what support was needed. Jill's priority was to talk about how she had called one of the helplines that exists in another hospice, only to be informed that actually she'd been discharged. So that was that. They could do nothing more for her. This left her really confused about what was going on, about who does what. She began to feel really anxious and let down. And I tell you, this is a woman who is on it. She's very strong. And as I said, you wouldn't know that there was too much the matter with her if you met her. But this started this overwhelming feeling of anxiety. Who's doing what? I thought I'd be able to get help. I thought I was under specialist palliative care, but she'd been discharged. And she wanted to know what she can do out of hours. What happens if she needs to get advice about her illness without going into hospital again, because she's got a husband to look after. And she wanted to know how she can make her wishes known. They want to remain independent. Jill doesn't want to go into hospital, and she wants to focus on living until she dies. So Lewis Manning Hospice Care nurse went in, and we did put in place an advanced care plan for her. We offered respite sits, complementary therapy, counselling support, that's pre-bereavement support, and signposting. And we sorted out the concerns in terms of advice as far as we could. But it's a very good example of fragmented care, and the fragmented care that's happening in Dorset at the moment at end of life. That who's doing what, which the strategy initially sought to help resolve. Looking at how people are supported at each stage of their life, how the communication works, and this difference between reactive and proactive care, both of which is needed in Dorset. Judith, if you could move the slide on, please. So Jill's short case study there, I feel really does demonstrate the importance of the Macmillan bid and the Macmillan funding that we've applied for. We're talking about early intervention that gives a better patient experience and saves costs on avoidable admissions and gives much more positive outcomes, importantly, to the patients and their families. Thinking about 2024, of the 9,936 deaths in Dorset, only 24% of those people had advanced care plans. And the Macmillan bid seeks to get that to 80% of those people dying. We want to ensure that patients are on the palliative care register to get up to 85% of those total deaths onto the palliative care register, so that we can start to recognise those people and start to work with them, as was alluded to through the INT presentation. The importance of advanced care plans is to ensure that patients' wishes are recorded and understood, which was one of Jill's worries and concerns. And this is not unusual in terms of frailty, loneliness and end-of-life patients. A 24/7 helpline for all, not for people during the time that they're in a specific service, because we experience every day, it takes time to die. And actually, if you're in a service for a specific time and you're given a helpline number, when you get discharged from that service, you're still dying, but you need somebody to get hold of and ask those questions so that you don't have to go into hospital or ring your GP. It has to happen both in and out of all services. The last week of life options for people, there need to be more of them for people who want to remain at home. And since about 43% of the dying population are over 86 years old in this area, and again 43% of the dying population are actually in the BCP catchment area, it's absolutely pertinent to what we're looking to do. And I think improving how the 3 hospices in East Dorset need to work together, both in communication, collaboration, partnership, delivering cost savings, so that there's a one system approach for the patient. Because at the end of all of these great words and all of this great work is a person. And I'm sure all of you will have experienced some form of death in your time through a loved one or a friend. And we have to keep the person at the centre of all of this. So I've got one further example just to show you, and this is not so recent, but just an example. You may have seen this slide before, but an example of the last 12 months of life. So this is a gentleman who in the last 12 months of life, bearing in mind you've got about 360 something days left to live, and he was admitted to hospital 11 times. He saw 9 different consultants. Of that 360 odd days, he spent 87 days in hospital and had numerous very expensive tests done to him, because actually our NHS is amazing at making people better, but actually we need to be better as a system in terms of helping people to have a good death. And his partner, after he died, said that everybody wanted to do their best and everyone did the best they could, but there was no one overseeing what was really happening. No one seemed to be taking a step back and looking at the bigger picture. What was going on? They just all did their bit. And he could have been saved so many admissions into hospital, and the system could have saved so much too in terms of money. And it is believed, as you will have heard today, that so much of this activity is unnecessary and certainly modifiable. And more recently, back in February, we took a survey over 1 week of 112 patients who were in hospital and in hospices. And of those 112 patients, there was no evidence of any of them having an advanced care plan. They'd all had regular admissions into hospital in the last 3 months of life, some 1, some up to 11, like this gentleman. And of course, on top of that, there's the numerous testing that goes on. So I'm really pleased to have been part of this project, and really pleased to ask for your support and to welcome your feedback back on any thoughts that we can make this even better. I'll pass back to Judith. Thank you.
Thank you so much, Claire. I have to say it's been a real pleasure working with Claire and her team alongside other hospice providers and indeed BCP officers and Dorset officers to be able to bring this strategy to life in a way that feels the right thing to do at this stage. So in terms of next steps, Macmillan already put the money on the table. In terms of securing the funding, we need to take it through a number of sort of hoops and hurdles about being clear that we can use the money well and actually make contractual changes as a result. So that's going through its sort of final stages as we go out to Christmas, and we're hoping that as we go into the new year, the programme itself will actually start. Clearly that needs to be linked in with health and wellbeing boards and the integrated care system. So it's agreeing that approach and ensuring that this is a complementary programme to the other ones that you've been hearing about tonight as well. We'll appoint a coordinator, then we'll move on to putting in place the 3 elements of the plan, and then go forward to monitor and evaluate to ensure that actually we are doing the right thing in the right way and making those relevant changes for the people of Dorset and BCP. But at this stage, it'd be really lovely to have your questions, your thoughts, and any feedback, because it would be a great time for us to be continuing to develop what we've planned and plotted so far to ensure that it goes into the programme that we take forward over the next 3 years. So thank you.
Thank you very much indeed, and thank you so much for highlighting those patient experiences. It's so important that we hear that at first hand. So thank you very much indeed for that. I am going to, I've got a list of questions, but I'm not going to hog the chair. Just look around the room to see if anybody's got any questions, please. I will hog it then. So I'm assuming that the money that you're hoping to secure from Macmillan will pay for those things that you identified you wanted to do, i.e. the single point of contact and the 24/7 support line, and I'm guessing also the appointment of a coordinator. So I'm assuming all of that money that you're hoping to get from Macmillan will pay for all of that. So I'm guessing that that's good. Who's going to do it? Where are those people going to sit? Who's going to employ them?
We're just sorting that out at the moment, Claire and I. We don't think it will be, well, almost certainly it won't be an ICB appointment. We want to be able to go out into our group of providers. We'll have a steering group over this and then appoint either through one of our hospice providers or indeed one of our local authorities. We're fairly open about where that should be, but we want it preferably people who are connected in with the community. So that's the way we'll take that forward. Yeah.
Okay, thank you. Any other questions? Okay, well, thank you ever so much for that. I'm just going to deal with the recommendation, if I may, which is that the committee note the proposed strategy for palliative and end-of-life care in Dorset. Is that everybody content with that? So just, you did highlight the next steps. What would be the next steps for you once you've been through that hoop of getting it through the health and wellbeing boards? Is there another step after that?
No, once that, because Macmillan have already signed it off, they signed off, they said that we could have the money back in March. So they're very happy that we get the money. It's just us working it through at the moment to ensure that, because there are so many moving parts on this, that everybody's happy with where we go, because the social investment creates a direct loop to ensure the continuity overall. It means changes in all the contracts that we have in order that we can then sustain it thereafter. So everybody's got to feel happy that this is the right thing to do.
Okay, well, thank you very much. Thank you. If there's no other questions, thank you both very much for your time.
No, it's been a pleasure.
I'm going to move on.
Thank you very much.
Thank you. No, thank you. So we move on to item 11, which is the Overview and Scrutiny Annual Report. We have Lindsay online in case I managed to mess this up, but as far as I am aware, this is for information only. It's been through the Overview and Scrutiny Board. It just outlines, the work of the Overview and Scrutiny committees. Is there anything else you would like to add, Lindsay?
No, I don't think it's necessary unless there's any questions or anything that people want explaining about the report.
Anything? Is everybody happy? Thank you very much. Well, thanks, Lindsay. I'm going to move on then to the work plan. So the intention is to do a complete refresh of the items that we think we ought to be looking at early in the new year. So we will be asking everybody again in the new year what items they want the committee to look at. I just wanted to highlight a couple of things, if I may. Obviously, we've talked about the future care thing earlier on, and we might see if we can find some time in the March agenda to include that. But I just wanted to highlight the issue that I raised earlier on, which is about the health and social care for homeless, which we did take to Cabinet back end of last year. But also we'd had some communications recently from the team that are coordinating the work of the health bus, who are keen for us to have another look and see how far we've come with that piece of work. So again, we'll try and find some time in the new year to have another look at that. You remember that was a report that originally came from Health Watch about the healthcare services for the people who are homeless. So we try and, as I say, fit that in to see where we're up to with that. And also, some time ago, Councillor Simon raised the issue about the impact of the government's changes on welfare benefits as to whether or not we should look at that in terms of its possible impact on BCP services. So what's happened since then is that the senior officer team within adult social care received a report from the Citizens Advice Bureau about how they saw it in terms of the impact on residents. And they've more recently, excuse me, they've more recently been keen to ensure that the residents who are in receipt of these benefits are aware of the sort of changes that are coming. So there's been a bit of toing and froing with the communities team about that, but hopefully you'll have seen the notice that's gone out about the briefing that the CAB is going to provide on the 10th of December. So that's open to, the intention is that will be open to everybody. And I hope as many of you who would be interested will be able to come along and hear what the CAB have got to say. And certainly from my point of view, what I'd be keen to do is just to get the feedback from councillors who hear that presentation about what more work we should be doing as a committee to look at the potential impact on our services in relation to all of that. So that's I think all I wanted to say on the work plan, unless anybody's got any questions. Betty.
Yeah, I think just obviously to say that in the new year, you might, one of the things for the work, for the agenda and the work plan might be around the inspection of adult social care. I'm sure you have that on, Chair, as well. I'm sure you have that on your agenda, because we will know the outcome of that in the new year. Thank you.
Yes, thank you. I wasn't going to steal Councillor Brown's thunder to talk about CQC, but they're here, they're with us, they are in our midst. I'm sure the team will do a brilliant job. But yeah, we have a briefing scheduled in the work plan for January, so we'll see whether that's an opportune time to use that for a bit of feedback from the inspection if we are in a position to let you know anything at that point. Is there anything else anybody wants to ask or raise on the work plan? Okay, if not, then Councillor Brown, over to you. Thank you.
Thank you, Chair. Thank you for, as always, saving the best till last. I shall be doing the same as well. I've got a few just sort of updates on just which are hopefully of interest, things I've been up to the last couple of months, and hopefully you'll be able to see how some of the things that are ongoing link into the sort of discussions that you've been having. Since the last meeting at the end of September, beginning of October, I went along to a conference meeting in Dorchester, the Transforming Health and Care Together, a voluntary community sector event. So it's to brief representatives from the voluntary sector right across Dorset about developments within health and care. And I spoke to them a bit on the Adult Social Care Fulfilled Lives programme. And fortunately, I'm going to give a shout out to a few different people as I go through. Tim's just gone, but I managed to use, if you remember the slide he shared at the last meeting, the nice animated graphic about the 3 conversations model. So I managed to pinch that from him and take the credit for it at this conference event. And actually, I had some really positive feedback, just so that the voluntary sector are aware of the sort of what's going on within BCP social care and that sort of different way of working. And also at the meeting, Future Care representatives were there, and that was sort of discussed in quite a lot of detail. And I think something which was a little bit missed within the Future Care discussion earlier is about the involvement of the voluntary and community sector within that, and certainly within the hospitals around transfer of care hubs, and the voluntary sector being able to sort of link in and provide services to help people when they're discharged from hospital. So I think there's a really critical part that they are already playing within the Future Care programme, and we shouldn't overlook that. Other matters, on the 4th of November, I had the Leaders Live question and answer, live on YouTube and Facebook and social media channels and stuff, which was actually all on wellbeing. And thanks to Rob and his team, prepared some information, particularly on vaccinations, so we were able to get the message out about sort of seasonal vaccinations. And there wasn't too many questions about wellbeing. A lot of it's about car parking and streets and stuff, but we do our best to get the message out there. Also in November, actually, relating to what Sian had to say earlier about the Dorset and BCP Safeguarding Adults Board, we had their SAR learning event, the Safeguarding Adult Reviews learning event. And I think there's probably a couple of hundred people on that call, which is really good, because it's those sort of serious cases where actually there's a sort of deep dive into what's happened, why it's happened, and what the learning is from it. And the Sian and the Safeguarding Adults Board were able to sort of share that learning, not just from local cases, but from actually national cases as well, to hundreds of our staff and healthcare staff as well. So that's a really sort of, I think, just a really critical part of what the Safeguarding Adult Board deliver, to make sure that that learning is really sort of passed out and embedded within all of our teams. Was it last week? It was only last week, actually. Yeah, just to give a shout out to Rob, we had the Joint Strategic Needs Assessment and Health and Wellbeing Board Strategy Workshop last week, which again, we had quite a good spread of representatives within BCP and from health partners and other partners to input to what our Health and Wellbeing Board strategy is, and also making the most of the Joint Strategic Needs Assessment, which has been updated. And so I think that was a really positive day. Also last week had the Learning Disability Partnership Board as well, which is a real good example about sort of co-production. They're working on their big plan for learning disability services and preparing for that to go out to public consultation in the next couple of months, and that will then eventually come back to Cabinet, I think, in the spring, hopefully. I'll mention CQC assurance a little bit. Betty's left the room, but I think probably most of my portfolio holder updates the last year or so, I keep talking about preparation for CQC assurance. Well, I don't have to talk about that anymore now, because they're here, so we're not preparing anymore. We're actually going to be seeing them. But I was at an event a couple of weeks ago. Oh no, it was last week actually, the Learning Disability Partnership Board, and some of our senior sort of heads of service I was speaking to. And they were actually quite looking forward to it in a way, because they said actually now it's here, they're actually wanting to tell our story and all the good work that's gone on, and how we've sort of really changed people's lives and help people's lives. So actually, I think a lot of the sort of senior officers are really, I don't know if looking forward to the CQC visit is the right terminology, but they're really looking forward to being able to share what they've got to say and share the sort of news about what they managed to deliver, and so yeah, I think it's got to that point now where we're keen to sort of talk to them and show them what we do in BCP. Another little mention, actually, in relation to Rob, we've got a lot of new sort of senior staff joining us over the next month or so, really, isn't it? Rob said to me today that we've had 2 of our new public health consultants join BCP Council today. Another one's joining in January, and we've obviously got Laura Ambler joining as our Corporate Director for Wellbeing in January. And for me, I think there's a lot of good stuff going on with adult social care and within public health, but it's nice to sort of be bringing sort of new talent into the organisation that's really going to help us sort of push on and develop what we do. You know, we know that budgets are tight, that times are hard in terms of finances, and there's a lot of pressure within adult social care and within our health services. But to know that we've got sort of talented people coming into the organisation and joining us is a real sort of a sign of optimism for the future, I think. And I said I'd save the best till last. So I wanted to relate back to September meeting where you as a committee discussed the adult social care prevention strategy, and were supportive of it. But as you'll recall, there was the gap in it was that this is all very good, lots of real detailed strategy, very detailed plans, but where's the money coming from and how are we going to fund the delivery of this? For me, it's quite a nice case study of Overview and Scrutiny have looked at it, they've supported it, they want to back it, but actually what are we going to do following that? So over the subsequent weeks, I know Zena was having sort of discussions with our Director of Finance, and I saw various sort of spreadsheets of figures being prepared, and then ultimately on the 29th of October it came to Cabinet, and Cabinet have not only approved the adult social care prevention strategy, but put up in excess of £1 million funding over the next 3 years to back it and to deliver those services. And actually, I just wanted to sort of just quickly read through the recommendations that Cabinet approved. So they approved the adult social care prevention strategy. They've approved an investment of £203,000 ongoing funding for adult social care prevention strategy, so that's annually, to counteract the effect of temporary funding not being available from next April. So there was certain sort of one-off funding or short-term funding that was going to run out next April. For example, the BCP handyman service was only funded up to next April. But Cabinet have now approved an additional £203,000 a year revenue funding to back the prevention strategy. And that means that the BCP handyman and those teams are going to be keeping going out after next April and keeping doing all the good work that they do, as well as, I mean, that's one sort of very visible example, but there's lots of other services that will continue to fund. And the Cabinet has also approved an investment of a further £441,000 over the next 3-year period, so that's £147,000 a year, to be drawn down from flexible use of capital receipts to increase the total adult social care prevention strategy envelope to the required level. So there's additional funding in terms of sort of transformative funding to deliver that programme. So I think that's really quite exciting, and that's quite, for me, it's a nice case study of how things have worked. Officers have sort of, there's been a lot of work, an awful lot of work over months and months and months to bring that strategy together and get all the thinking together. Scrutiny have looked at it, Cabinet have listened to that, and actually it was my job to sort of persuade my Cabinet colleagues that, you know, that times are hard and it's difficult to get funding for things, but actually it's one of those areas where not only will the funding, it will more than pay for itself over the coming years in terms of reducing the pressure on our social care services. But so it's not just a financial thing, it's actually going to deliver some incredibly better services for our local residents and help people stay at home for longer, keep their independence, and actually help people be healthier and be better supported over the coming years. So it's one of those areas where it's good for the council's finances, but it's also good for our residents, and managed to get that message across. And thank you for your sort of consideration and support of that at the last meeting. So, and subsequent to that, I then attended, was it a couple of weeks ago, the Adult Social Care Commissioning Away Day. And actually it was really nice to then meet some of the teams of people that will actually be working on the prevention strategy and all of our other sort of commissioning colleagues. And there were some really sort of outstanding examples, I think, about where some of our teams really go above and beyond to deliver for our residents. And just one example, which we've mentioned before, was about NRS Healthcare that went into liquidation on the 1st of August, and the way our team sort of stepped up and meeting the people there that had been involved in that, in terms of getting Mediquip, a new supplier, on board to do our sort of integrated community equipment service, and managed to keep that going despite really sort of tough challenges, and you know, working a lot. And I think I heard a case of somebody from Mediquip drove up from Cornwall with some equipment to somebody up in Dorset. They weren't there, and then they started heading back, but then the people got home, phoned them up and then he turned around again and came back to deliver the equipment. So it was that people were really sort of going above and beyond to make sure that people had what they needed to sort of have the support and care they need at home. So and I think there's reasons to be sort of optimistic about that. They're looking at a new depot for Mediquip locally within the local area that's going to be really good to service the whole of the conurbation. So yeah, a real sort of some really good work to overcome a real sort of challenging issue. But actually, again, reasons to be optimistic in the future about how that service is going to be delivered locally. And I think that's everything. So yeah, there's also obviously a lot of budget discussions going on at the moment, and it's not going to be easy sort of producing a balanced budget. But certainly I think that the way that we're working within adult social care, within public health, to actually think strategically to make sure that actually we do sort of manage the future pressures that we know are going to face us as people get older. We're working imaginatively, we're working innovatively, and we've got good, talented people coming on board joining BCP. So I think there's sort of tough challenges ahead, but there's definitely reasons to be optimistic about where we're going. So.
Thank you, David. Any questions for the portfolio holder? Okay, got off lightly there, David. Okay, thank you, everybody. Thanks for your time. Thanks for your input, and we'll see you next time. Oh, and if I don't see you before, Merry Christmas. Everybody keeps wishing me Merry Christmas.